Okay, well, welcome everyone to pediatric teaching for today. I hope you've had a good start to the week. Today I wanted to talk about, instead of talking about a particular topic, I wanted to talk about a series of cases that teach us about common critical illnesses in children and how using basic tools such as triage checklists and the WHO hospital care for children approach to the stages of management, and how using a intensive care approach, if you like, to what is required in the first hour of managing such patients and then ongoing, how you can use all of those things to manage quite complex illnesses successfully, even if resources are fairly limited, because most of what we do is fairly basic. Most of what we do is 80% of what we do, at least, for even common critical illnesses, is all the things you know how to do with the resources that you have. So we're going to talk about 4 different cases today, and I hope they illustrate what I'm trying to convey today. The first case, I just want you to look at this child. This was a 19-month-old boy who had presented with 5 days of cough and fever and respiratory distress. A very common presentation, isn't it? Cough, fever, and respiratory distress. We see children like that all the time. And you can tell by looking at him how severely ill he is, because he has some significant emergency signs right from the start, doesn't he? He has very severe chest wall indrawing. Now, he had a respiratory rate of 70, so again, marked tachypnea, severe chest indrawing that you can see in the photograph, a heart rate of 170, and a saturation of 82. So already in the first 30 seconds of looking at him, you can categorize him into a child who has some emergency signs. When going beyond that, when you auscultate his chest, he had a very prolonged expiratory phase. And as you may know, the phase of breathing in is usually longer than the phase of breathing out, because the phase of breathing in a person who's well requires active muscle contraction. We breathe in with muscles and then we breathe out just by relaxing the muscles. And usually the phase of breathing out is a bit shorter than the phase of breathing in. But if you find, when you're looking at the patient or when you're listening to the chest with a stethoscope, if you find that the phase of breathing out is much longer, much more prolonged, then the child has some form of expiratory airflow obstruction. This is a very common clinical finding, but often missed by doctors and nurses who haven't learned how to assess the phases of breathing in and breathing out. So I want you to practice that and learn how to assess for prolonged expiratory phase, and which indicates expiratory airflow obstruction on expiration. The child also had wheeze. So when you listen, usually when you hear that prolonged expiratory phase, you're hearing wheeze. And often the patients also have crackles as well, because what crackles reflect is just secretion in the airways. As the air is moving in and out of the airways, then it's moving through secretions, and that's what crackles are, either at the alveolar level or in the airways itself. And the last thing about this child, you can see the boy's hand was also very pale. So already we've got an idea that he's got severe respiratory distress, so you might say severe pneumonia clinically, but he's got prolonged expiratory phase and lots of wheeze and very pale. So again, this child has clear emergency signs and puts this child in the triage emergency category. Remember, we said just going back to basics all the time. We should go back to basics about how to look after any sick child. There's the stages of management of triage and giving emergency treatment, and taking a history and doing a full examination and doing laboratory investigations if required, and making a diagnosis and then making any other diagnoses. Remember, the child might have more than one diagnosis, and if we only diagnose one problem and miss the others, then the child won't get better. And then giving treatment, and then supportive care, which could be fluids or nutrition or a blood transfusion if needed, or anything else, antipyretics for a fever, etc. And then close monitoring, which we've said should be done with ideally a color-coded monitoring and response chart that's specific to pediatrics, that enables you to identify when a child's improving or deteriorating. And then discharge planning and follow-up. They're the 10 stages of management of any seriously ill child. And if you go through those stages with every child, then the outcome will be as successful as it can be. Remember, in triage only takes that minute, a first minute. You take a brief history of the presenting problem like we did at the start in the first slide. You take the temperature, because that's important to know whether this is a febrile illness or an afebrile illness, and weigh the child. That's important because then you can prescribe medications appropriately. You listen for stridor or obstructed breathing. Clearly, this child had obstructed breathing, but it wasn't at the upper airway level. It's more in the lower airways. You look for cyanosis. This child had saturations of 82, so likely to be cyanosed, and look for signs of respiratory distress. With this particular child, he was so pale that he may not have cyanosis. So children who are very anemic won't always be cyanosed. That's an important point. And you look for signs of respiratory distress. He had severe chest indrawing and tracheal tug, and you check the oxygen saturation. That's B. And then for the circulation, remember, you feel the skin. If you feel the hands and the feet, that will give you the most information about the child's circulatory state. And you feel the skin temperature of the hands and feet, feel the pulse volume, and check the capillary refill time. Remember, I said you should get good at assessing that in all children of all different ages, because their pulse volume feels a bit different from neonates and infants and children and adolescents, and you should assess those things just in the hands and the feet. That gives you the most information, and if you can also check the blood pressure as well, that's even better. And then for D, disability or conscious level, you should assess for lethargy and the level of interaction the child has, and then put it all together as to whether this child has emergency signs or not. Now, remember, we said this child's got obstructed breathing and severe respiratory distress and central cyanosis, so he has all those things. He didn't have signs of shock, although was very pale. Wasn't in coma, was still reasonably alert, didn't have convulsions, and didn't have severe dehydration. But even though he doesn't have some signs, if you find any sign at all, any of these emergency signs, then you stop and give emergency treatment. And in this case, the emergency treatment was clearly oxygen for his hypoxemia. Salbutamol was given for wheeze, Ventolin nebulizer for wheeze, antibiotics for pneumonia, and he had an assessment of his hemoglobin because he was so pale. So all those things can be done at least in the first hour. There's a concept in emergency pediatrics, in intensive care, of the golden hour, and I think it's quite important. If you consider all the emergency treatment, all the things that need to be done in the first hour to get the child stabilized, and try to get all of that done, whether it's an intravenous drip, whether it's antibiotics, whether it's oxygen, etc., some essential investigations. Do try to get all of that done in the first hour, and then you have a good chance of stabilizing a patient. Sometimes you can do it much quicker than an hour, but there is a concept of a golden hour in critically ill children, in children or patients with trauma, and other seriously ill patients. This was the child's chest X-ray, and I think you can see from the X-ray, you can see a couple of things. One, when we're looking at an X-ray, we went through this a couple of weeks ago about how we assess patients' lungs, and of course you want to assess the basic things of the position of the chest X-ray, whether it's a well-penetrated film, whether it's a rotated film, etc. But when you look at the child's lungs here, you can see how flattened the hemidiaphragm are. And so remember we talked about the categories of lung disease being small volume lung disease, like it occurs with severe pneumonia, or like occurs with respiratory distress syndrome in neonates. Small volume lung disease because there's consolidation, there's fluid in the alveoli, etc. Or large volume lung disease where you've got airflow obstruction. Air can get in, but the child has difficulty exhaling the air. And in this case, with this child, remember we heard very prolonged expiratory phase, which means there's some expiratory airflow obstruction. And you can see that the lungs are very hyperinflated and they look more black than normal, don't they? You can't see the lung markings as well. And that's because there's more air in the lungs that can't get out. And the other clue is that the diaphragm are very flattened. They're pushed down because of the hyperinflation of the lungs. And we need to think to ourselves, well, what are the causes of lung hyperinflation? And we've gone through this before, but the causes include bronchiolitis in infants and children up to the age of about 2, or asthma in an older child, or a child over the age of 1, or a child who's had multiple episodes of wheeze. They're the main ones, and then there's some other ones that you need to think about, such as an inhaled foreign body or some congenital malformation leading to excessive lung hyperinflation. So asthma, pneumonia, of course, but this doesn't look like pneumonia. It looks like large lung volume disease, asthma or bronchiolitis, or perhaps an inhaled foreign body even, or congenital airway obstruction. And the questions you need to ask in a child who's got, if a child has large lung volumes and wheeze, is it asthma or is it bronchiolitis? That's often the question that people ask, and it's difficult to answer. But the question you can answer to yourself when you're with the child in a clinical sense is the wheezing likely to be bronchodilator responsive? In which case it's more likely to be like asthma. And so if a child's of a certain age, more than 9 months, if they've had a previous history of asthma or bronchiolitis, if a child's had multiple episodes of bronchiolitis, then they're quite likely to have bronchodilator responsive asthma. Okay, if they've had several episodes of RSV in their first year, then often those children, not all the time, but often they go on to get wheeze or asthma in the second and third year of life. If they've got atopy like allergic rhinitis or eczema, and then you try a trial of therapy. And often people think a trial of therapy is just one nebulizer of salbutamol. Well, sometimes with the first trial of salbutamol, you don't get very far. The child doesn't improve that much. And you need to give a series of doses over the first hour. And I'd often give 3 nebulizers over 1 hour and see if there's a improvement, if there's a response. So give a proper trial if the child's had if you think the child is old enough to respond, more than 9 months, if they've had previous episodes of wheeze, etc. So it's good to do a proper trial in the first hour and see if the child has bronchodilator responsive wheeze. And the reason to do that is because if the child does have wheeze that's responsive to salbutamol, then you can institute other therapies that might benefit a child who has asthma, as this child did. I want you to just look at this. We've started to use pediatric monitors in the last year or so, and I want to point out one important thing you can tell from a monitor, and just look at the saturation trace, because we're used to looking at the SpO2, and normally we just look at the number 97. So this child, when given oxygen, had a good saturation. The heart rate was still high, so the heart rate was 180. The blood pressure is, don't worry about that too much. But I want you to look at the saturation trace and see what you, just more than the number. Just look at this. you can see how the saturation trace rises and falls. And at the same time, I now just look at the blood pressure and just see what happens. You can see that the blood pressure trace rises and falls with the saturation. Now, mostly we don't have the blood pressure trace, but we always have the saturation trace. And what that reflects is a form of what we call pulsus paradoxus. It's like pulsus paradoxus, where you get a rise and fall in the blood pressure with breathing. Now, we all have a little bit of that, but when you see it so exaggerated as that, then that suggests the child's got major changes in intrathoracic pressure throughout the respiratory cycle. So, and that occurs if you've got severe expiratory airflow obstruction, because when the child's breathing out, they have a marked increase in their intrathoracic pressure, and so less blood comes back to the heart, and so their blood pressure is lower, and their saturation trace that's where it dips down. Whereas when they're taking a big breath in, then that leads to an increase in their saturation trace. So this child's got pulse wave variability or saturation variability that occurs throughout the respiratory cycle. And you see that in children who've got severe asthma, in children who've got severe bronchiolitis with severe airflow obstruction, or in children who've got severe upper airway obstruction, like in croup. So where you've got major changes in intrathoracic pressure that differ throughout the respiratory cycle, it's just a clue to the severity of the child's illness. And now that we're starting to use pediatric monitors like this, I just want you to be alert for this clinical sign. You can also see it, this clinical sign of a rise and fall of the saturation trace, in children who have severe dehydration. And that's because they have variability in the blood that's flowing into the heart and out of the heart in different phases of the respiratory cycle. So when you see this sign, you should be assessing for expiratory airflow obstruction and also for their hydration state. It's simple like that. Yeah. Okay. So I wanted to just briefly touch on the therapies for asthma or acute bronchoconstriction. Remember, bronchoconstriction is just a constriction of the airways that's triggered by various stimuli. But as you know, the treatment for first-line treatment for asthma is oxygen if the saturation is low, salbutamol, and you can give it as frequently as every half hour or as infrequently as every 4 hours, depending on the severity. So you need to titrate it to the severity of the child. For very severe asthmatics, I would give it every half hour or even almost continuously in the first few hours, just until they've improved. But sometimes you're giving it every hour or every 2 hours is enough. Oral corticosteroids, if they're not that unwell, every 24 hours, just once a day for 3 days, or if they're very unwell, then giving it every 12 hours or giving IV therapy. But this is first-line therapy. And then a medicine called Atrovent or ipratropium bromide is also effective. That's a cholinergic agent that you can give every 4 to 6 hours. Again, that comes either in nebulized form or with a metered dose inhaler. But the main thing is most of the benefit in asthma will come from oxygen, salbutamol or Ventolin, and steroids. In terms of second-line therapy, if the patient is not improving, like this child was struggling to improve with just salbutamol and corticosteroids, oral corticosteroids, then you have to think about intravenous therapy. And in this child, giving magnesium was very useful as a single dose. It's an important bronchodilator. And sometimes if the child's very sick, giving magnesium and aminophylline, so as intravenously as a loading dose and then every 6 hours thereafter, and changing from oral corticosteroids to intravenous methylprednisolone or intravenous corticosteroids can be quite useful, and giving it up to every 6 hours is what you sometimes need to do. And then the third line therapy is if the child's still got severe respiratory distress after you've done all of that, then positive pressure support with CPAP or whatever. Magnesium is a little bit new to us in terms of its effect on asthma. I won't go through all of it, but there is a clear mechanism by which magnesium helps in relax the bronchial smooth muscles. It blocks acetylcholine release from cholinergic nerve terminals, so it causes bronchodilation. It acts in a way that it blocks this transmitter called NMDA, and that's how ketamine, that sedative agent, also can work in asthma. If you need to give an anesthetic to a patient, then you usually use ketamine if they've got also asthma. Magnesium also has an anti-inflammatory effect, and as you know, asthma is both a condition of bronchoconstriction, but also mucus production and inflammation, and magnesium is an anti-inflammatory agent that's useful in asthma. It's highly effective in asthma as a second-line therapy. Unfortunately, you can't give it nebulized. Some people have tried to do that, but it's probably not very effective. You have to give it intravenously. We don't know yet whether it works in bronchiolitis. Probably not, but it certainly works in children with asthma. So if I have a child who is bronchodilator responsive, when you give them a trial of salbutamol, then but yet they're not improved sufficiently and they're still moderately or severely unwell, then adding magnesium on top of that. We've got magnesium. It's magnesium sulfate, 50% solution, and you can give 0.2 mils per kilo intravenously over half an hour, and that's often very effective second-line therapy for children with asthma that's not responding fully to salbutamol and corticosteroids and oxygen, etc. I thought it's worth, we haven't talked too much about asthma, but it's worth just knowing what the triggers to asthma are and which children get asthma. Asthma's it's not a new disease, it's a very old disease, but I think it's increasing in some countries where there's the conditions are right for asthma. So we'll see more and more children with asthma as a component of their disease, their respiratory disease, and it's not good if we just treat them all like they've got pneumonia. So you need to be able to identify children with asthma from those who've got pneumonia, for example. But certainly most asthma is triggered by viral respiratory tract infections, but also other risk factors like smoke exposure. If people in the family smoke, especially the parents smoke, then many children get asthma. As I said, if children get multiple viral respiratory tract infections, RSV, throughout the year, then they're likely to, if parents smoke, and especially if they're not breastfed, then they're likely to get wheeze and asthma. In some places, major weather changes affect asthma, and there's a concept of what's called thunderstorm asthma, when thunderstorms come, when there's high humidity, and when there's pollination of plants, that can lead to pollen being circulating rapidly throughout the air and people inhaling that and getting very bad asthma. It's microscopic, you don't even notice it, but sometimes when there's major thunderstorms and high humidity, then there'll be major outbreaks of epidemics of asthma. Asthma also comes from much environmental problems. And if children live in houses where there's a lot of mold and dampness, that can be a trigger for asthma, or air pollution. Some children are sensitive to certain pets or animals, the dander from certain animals, the hair or from certain animals. And then there's a couple of drugs that can trigger asthma, non-steroidal anti-inflammatory drugs like Nurofen or beta blockers. They can trigger asthma in people who are susceptible to asthma. And then some children have their asthma triggered by gastroesophageal reflux. They reflux their gastric contents and aspirate a little bit, and that can cause bronchoconstriction. And some children have a type of asthma that's triggered by exercise. So when they go for a run, they get very wheezy, more so than they would if they just were exercising normally. And then for some children, anxiety or strong emotions can trigger their asthma, but usually it's a combination of these things that triggers asthma in a child. There are certain other risk factors for asthma. If a child's got a family history of asthma or eczema or allergic rhinitis, as I said, if they've got exposure to smoke, if they're preterm babies or ex-preterm babies, or they're low birth weight, and in some communities, if more overweight children are more at risk of asthma for lots of complex reasons. And as I said, poor quality housing or mold or dampness is very common for children with severe chronic asthma and air pollution. So that's asthma. That's what I wanted to just convey some things. We'll talk a bit more about the chronic treatment of asthma in a later talk, but I wanted to talk about just acute asthma management and how to recognize children with asthma from those children who have other respiratory disease. We can answer any questions about that at the end. The second case I wanted to talk about was case number 2. This was an infant who, a fairly common sort of problem really, a 4-month-old boy, had a background of failure to thrive. He'd been doing okay for the first month, and then in the last 2 or 3 months he'd been losing weight. He'd had sort of recurrent episodes of diarrhea. So he was a scrawny baby, a skinny baby with quite a bit of diarrhea. And then he'd had 2 days of fever, sudden onset of fever and respiratory distress and severe tachypnea, fast respiratory rate of about 60 or 70. He had a temperature of 38, over 38, and a heart rate of 180. And his saturations when he presented were only 65 to 70. This was his full blood count. All we knew in the first hour was his clinical state and his full blood count. So he had hemoglobin 11, that seems okay. A white cell count of 6, that seems okay. And neutrophil count of 5.8. And lymphocyte count that was pretty low. We often see low lymphocyte counts, don't we, in children who've got viral respiratory infections. And a platelet count was a bit low, but it was okay, 130. And this was his chest x-ray. And I wonder if anyone can see anything on the chest x-ray that you might want to highlight. This is a child with sudden onset of severe respiratory distress and hypoxemia. Often on an x-ray, we look for the white shadows that indicate consolidation. But in this case, there are some of those, but I also want you to look for blackness in places where it shouldn't be. And this is often we miss this clinical, this radiographic feature, and that is looking for blackness or air in the places where it shouldn't be. And there are a number of places where there is air, but there shouldn't be. There's certainly air in the lungs. There's no doubt there's air in the lungs. That's okay. There's a bit of white consolidation behind the heart border and some air bronchograms. So you might think to yourself, well, there's some consolidation of the lung. There looks like some air bronchograms in the right, middle, and lower lobe. But it's the blackness, the air in places that there shouldn't be, is what I want you to look at. And you can see the air. This looks like a line of air going up this child's neck. Of course, you normally see the air in the trachea and the bronchi. You can follow the bronchi and the main airways. But outside that, you shouldn't see blackness, certainly not adjacent to the neck. So this is air leak. This child has air leak of some sort from some organ in which there is air. And you need to think to yourself, if you see this, is the air coming from a leak within the lung or somewhere else? And this child had sudden onset of respiratory distress and has evidence of what we call a pneumomediastinum. It's not quite like a pneumothorax, which is in the pleural space. It's air within the mediastinum and also subcutaneous air. You can see it around his jaw here. There's air in places where it shouldn't be. And so when you're thinking this through, you've got to think, where is the air coming from? Could it be coming from his upper airway? a breach in his upper airway somewhere. Could it be coming from his lung? Could it be coming from his esophagus, even a breach in the esophagus? And this child has failure to thrive, recurrent diarrhea, severe hypoxemia and respiratory distress, and a pneumomediastinum, and he's got lymphopenia. And that I want you to be able to recognize at least that constellation of problems, that accumulation of problems, and see and be able to identify this as for what it is. So just to be clear, the normal levels of lymphocyte counts for age up to 2 years, it's 3,000 or 3 in this circumstance. From 2 to 6 years, it's a bit less, 2,000, and 6 to 18 years, 1,500. Lymphopenia is very common in viral infections, but if it's persistent, we should think, could there be an immunodeficiency? So, for example, could the baby have HIV or some congenital immunodeficiency? And what could cause this air leak? That's the second question to be asked about this patient. And there's a number of conditions that we see that can cause air leak. And any condition where there's severe expiratory airflow obstruction, like asthma, we talked about before, or a foreign body that causes expiratory airflow obstruction, bronchiolitis, asthma, foreign body, that can cause air leak because it's the pressure inside the chest is high. If a patient's got heavy bouts of coughing, if they've got pertussis, whooping cough, or pneumocystis, or RSV, bronchiolitis, then they may get air leak. Or if they've got alveolar fragility, that is it's related to damage to the alveoli. So when you've got tuberculosis or a cavity in the lung from staph pneumonia or a pneumococcal or pneumocystis, that all leads to fragility or cysts or blebs in the lung that are air-filled and can easily burst when a child has a coughing episode. Or if they go on, if they Valsalva or anything increases their intrathoracic pressure. Or if you've got air leaking from the esophagus or from the larynx, from laryngeal trauma or esophageal perforation, that can cause pneumomediastinum. So if you see this clinical problem, then think to yourself, where's the air coming from and what's the underlying cause of it? So in this case, a child who's got severe hypoxemia, an air leak, lymphopenia, and failure to thrive, that looks a lot like pneumocystis. And this is another child with pneumocystis pneumonia who also presented with the same problem. You can see it's a bit easier to see this time. This is not pneumomediastinum. This is bilateral pneumothoraces. And you can see the lung being outlined there. The lung hasn't completely collapsed because it's very consolidated lung, but you can see the air in places it shouldn't be. The air is outside the lung in the pleural space. This was a child with pneumocystis pneumonia and HIV and presented with bilateral pneumothoraces. This is a child with asthma who has presented with severe air leak. And you can see air is everywhere in this child. There's air in the mediastinum, there's subcutaneous air, there's bilateral pneumothoraces, there's air even in the shoulder, in the soft tissues there. So sometimes when you get air leak and you have severe expiratory airflow obstruction, it will just continue to leak out the lung and fill up the soft tissues, and it can cause a tamponading effect on the lung and can be quite difficult to manage. Generally, you manage it with just high flow oxygen and treating the underlying problem, reducing the expiratory airflow obstruction and treating the asthma in this case. Right, so we've talked about asthma and severe respiratory distress, and we've talked about air leak. I wanted to talk about another critical illness that sometimes we see and we don't always recognize it. Much less common than asthma and even less common than air leak. But this was a 12-year-old boy. I just want to tell you the story of a 12-year-old boy who was previously quite well, and he was playing soccer with his friends, and he had a sudden collapse. He wasn't struck by a soccer ball or by another player. He just collapsed on the soccer field. and he was unconscious and he had no pulses, and he was given, his father ran over and gave him CPR on the soccer field. And when an ambulance was called, and they took this ECG trace, and I want you to look at the ECG trace and maybe think to yourself what it could mean. I guess we know what ventricular fibrillation looks like. That's just a fluttering of the heart, fibrillation of the heart that leads to the heart not pumping any blood at all. And we sort of know what ventricular tachycardia looks like. That's like a QRS complex that's relatively normal, often wide, but very frequent without P waves, etc. This is slightly different. This is a form of ventricular tachycardia, and you can see just like that saturation trace I showed you earlier, it rises and falls. It gets bigger and smaller. And this is a particular characteristic arrhythmia that's called of variant of ventricular tachycardia called Torsades de Poix. Torsades de Poix. This is Torsades, and it's a form of ventricular tachycardia that has the same effect as VT or even ventricular fibrillation. It won't, the heart will not be pumping blood. And so in this child, it's appropriate to do defibrillation to get the child back into a normal rhythm. And when the child, so this is ventricular fibrillation or ventricular tachycardia with Torsades de Poix. And sometimes it occurs in the setting of Wolf-Parkinson-White syndrome, which I'll show you in a moment. It was a case of in this child, and often it responds well to magnesium. If you can push the child's magnesium level up substantially, then sometimes you'll get relief of this Torsades de Poix. They need, as this child needed defibrillation at the time, but to maintain the child in a sinus rhythm, back in a normal rhythm, then sometimes using magnesium can help. So I've talked a bit about magnesium in asthma, and another use of magnesium is in, especially in Torsades de Poix or in arrhythmias in children. This was his ECG when he was defibrillated back into sinus rhythm. And I want you to be able to see the characteristic feature here, and that is, I'll just show you, that is that after the P wave, there is a what's called a delta wave that leads into the QRS complex. And a delta wave is the angular upstroke of the R wave. You can see instead of it going straight up, there's an angle to it. And that's called a delta wave. And a delta wave is characteristic of Wolf-Parkinson-White syndrome. So this boy had Wolf-Parkinson-White syndrome with Torsades de Poix that occurred all of a sudden because his magnesium level went low and because he was exercising. So this was after he was defibrillated and given magnesium. This was his X-ray, and this is an important condition that we often don't always diagnose properly. You can see, again, looking at the X-ray, it's not a small volume lung disease, is it? It's quite large volume lungs, and you can see his, there's patchy opacity on both sides, but predominantly on the right side. And it could be one of two things in this setting. After an arrest, after resuscitation, it's not uncommon to see this. And it might be because the child aspirates, or it might be because they've got what's called negative pressure pulmonary edema or acute pulmonary edema from an acute arrest. This child had acute pulmonary edema from the arrest. And you can imagine if your heart's not functioning for a while, then you get a buildup of blood within the lungs. And even with resuscitation, you've still got edema within the lungs. So negative pressure or post-arrest pulmonary edema is very common. And once the child's back in the sinus rhythm, you just need to give them lots of oxygen and lots of CPAP. He had CPAP for 24 hours and magnesium, and he got antibiotics for possible aspiration, and everything got better over 2 days. His ventricular tachycardia resolved, he was off oxygen, and he was much improved over 2 days. So just with a basic understanding of radiology and the clinical state of the child, the clinical features, and the ECG trace, you can treat such children, and with basic medicines, with magnesium and with with antibiotics and IV fluids, etc. You can manage such a patient. Okay, the last case I want to describe. This will be short, but we haven't talked too much about snakebite, and I think it's worth sometimes snakebite is not a critical illness. Sometimes it's an emergency, but sometimes it can be very children can be very critical. And I just wanted to convey this case. This was a 16-month-old girl who had a snakebite witnessed by some other surrounding adults. She was playing in a sand pit, and she was bitten by a snake, and she was actually bitten on her torso. The snake reared up and bit her multiple times on the torso, and she was brought immediately to a base hospital, and she was there within an hour or so. She was seen to be very drowsy and quite irritable, not moving very much. She was hemodynamically stable. Her airway, breathing, and circulation were okay. There was the staff at the hospital they had a venom detection kit, and so the sample was positive for a Papuan taipan. It's a bit like a tiger snake. You can see this is a Papuan taipan, and it has similar characteristics to a tiger snake. They were able to do a clotting test. This is very important in children who've had a snake bite with certain snakes. They're able to do a clotting test, and you probably know that the normal INR in a patient is about 1.3 to 1.4, depending on age. But this girl's INR was 12.9, very, very, very high. And her urine was already positive for blood, and she started to get bruising on her legs and arms, not just where the snake bite was, but in other places as well. So immediately she was given, or as soon as possible, she was given 2 vials of snake antivenom. And that was about 3 hours after the bite. At that stage, she looked comfortable, but she had a very limited movements of her arms and legs. And when examined, on full examination, she had rather reduced tone all over, and you could see the multiple puncture wounds on her body, not just one snake bite, multiple. So this is a very high risk snake bite because it's not just one lot of envenomation, there could be multiple envenomations. So she had multiple puncture wounds on her upper abdomen particularly, and so on that basis she was given a further vial of snake antivenom, and the repeat coagulation came down to 1.6, an INR of 1.6. So still a bit high, but much, much better than what it was before. And I think it's very useful to be able to do a simple coagulation test if you can, because that's the clue to understanding how envenomated a child is, both the clinical features and a coagulation test. And if the INR is high and the fibrinogen is low, this fibrinogen was normal, but to begin with, it was less than 1. If the fibrinogen is less than 1, then you've got a type of bleeding disorder. I did describe it last week, but a type of bleeding disorder that I'll talk about in a moment. Overnight, this child had, remember I said she wasn't moving very much, but she then developed pooling of her secretions, and she developed a stridor, an airway problem, and was very sweaty. And then so 22 hours after the snake bite, she was intubated to protect her airway and to help her breathing, because she was starting to become hypoxic and hypoventilate. And she was given then 2 further vials of antivenom, and you could see over the next day she had progressive paralysis, wasn't moving hardly at all. That her coagulopathy, this problem with her blood clotting, persisted for 2 days, and she was ventilated for 12 days with this snake bite, and it took that long for her muscle strength to return. So a Papuan taipan or a tiger snake, they both cause the same sorts of problems. You know, this child was severely envenomated. Most children are not so severely envenomated, but this child was very severely envenomated because she'd had multiple bites. And because when you've got a bite on a limb, then the first aid treatment is pressure immobilization, to apply pressure to the limb and immobilize the limb so that the venom does not enter the lymphatics and then into the bloodstream. But in the case of a bite on the abdomen, you can't really provide pressure immobilization to that part of the body. And so this child had multiple reasons for severe envenomation, being that pressure immobilization was not possible, that there were multiple bites, and she had some delay in receiving antivenom. But the key thing is to know what snake venom does. And some snake venom, like the Papuan taipan and the tiger snake, that they produce within their venom, there's multiple different toxins. One causes a consumptive coagulopathy. I talked last week about disseminated intravascular coagulation, how you have a procoagulant causing toxicity and causing thrombosis, and then consuming the coagulation factors, and then you get bleeding and a high INR. And this child with a taipan or with a tiger snake, you'll get consumptive coagulopathy. You also get a neurotoxin that affects the nerves and a myotoxin that affects the muscles. So her muscles and her nerves got very weak because of that. Some snake venoms also have a hemolysin that causes hemolysis. So those four things, a procoagulant, a neurotoxin, a myotoxin, and a hemolysin, they're the four major toxins within snake venom that you need to deal with. And you can see the features of this clinically in our patients. They sometimes drop their hemoglobin a lot. They lose their reflexes. They get severe muscle breakdown, and they get major bleeding and clotting. If the coagulopathy persists, like this did in this child, coagulopathy persisted for 2 days, the treatment is to give more antivenom. It's not to give, sometimes we give cold blood and those things, but you have to give more antivenom because you have to neutralize the toxin, and you have to give the right antivenom for the particular snake. So look, just in summary, that was the 4 cases. I thought they were interesting and varied, and they demonstrate multiple different things. Firstly, when we see a child with severe respiratory distress, we can make an assessment of them by looking at their airway, their lungs, and their heart, because sometimes it'll be a heart problem, sometimes it'll be a lung problem, sometimes it'll be an airway problem, and really trying to understand those things. We've talked about the causes of hyperinflation. We've talked about asthma therapy, acute asthma therapy. We've talked about pulsus paradoxus, this oxygen saturation variability. So when you see that next, try to take some time to understand what it means. We've talked about the causes of air leak within the lung and within the soft tissues. We've talked about the causes of lymphopenia. We've talked about a cardiac arrhythmia, Torsades de Poix, and the value of magnesium in that setting. And we've talked about snake bite and how a venom can contain all of these things: a procoagulant, a neurotoxin, a myotoxin, and a hemolysin, and the clinical effects of that. And lastly, that combines all of these things, we've talked about the golden hour, and the hour after a child presents, whether it's from burns or trauma or some other critical illness, septicemia, where if you can provide that essential emergency treatment, then the child will have a much better outcome. So I just wanted to, I'll stop there, but I wanted to share with you just a few cases that demonstrate multiple aspects of how to care for critically ill children, and demonstrate how you can do so even in settings where you have only basic resources. So thanks for listening today, and I'm happy to answer any questions that you might have. I'm going to stop sharing my screen now and pause the recording.